topic was neonatal hyperbilirubinemia. And I want to be very, very sure that we are going to just discuss only hyperbilirubinemia and physiological and both pathological, but nothing other than that. This is not about conjugated hyperbilirubinemia. We are not discussing connectors. That's a completely separate topic. The today's talk is only about hyperbilirubinemia in the newborn period. Next slide, Vikram. Vikram, can you do the next slide, please? Okay, so what is the normal serum level? In an adult, it is 1 milligram per deciliter, and an adult can appear jaundice if the bilirubin is greater than 2. On the other hand, the newborn does not appear jaundice until the bilirubin is greater than 7. So by the time a person or a clinician who is looking at a newborn and the baby appears jaundice, that means the bilirubin is already greater than 7 milligram per deciliter. And give or take, depending upon which part of the world you are, about 25 to 50% of the term infants develop some degree of jaundice. It's a pretty common condition and not something that you don't deal with commonly. And the percentage among the premature infant who develop jaundice is slightly higher than the term infants. So next slide, please. So to understand where the bilirubin is coming from, you have to first understand the heme molecule. The heme molecule is part of the hemoglobin. And when the hemoglobin is broken down, it releases the heme molecule, which is converted into biliverdin by the enzyme heme oxygenase. And then that biliverdin is converted eventually into bilirubin. And the metabolism of a heme molecule release 1 molecule of bilirubin and 1 molecule of carbon monoxide. And we'll talk about it, what's the relevance of carbon monoxide being released during this process. Next slide, please. So once the bilirubin is being formed, then the bilirubin is being transported in the blood. And this is a very important concept for people who are in the junior part of their career, that bilirubin is a non-polar and water-insoluble molecule. It is transported to the liver cells bound to the albumin. And this concept is important because not just the bilirubin, but other molecules are also trying to bind with the albumin, and they can displace the bilirubin. And those other molecules are usually the antibiotics, sulfonamides, moxilectams. It's a long list. I just put in a few of those. But look at the 6th point, the rapid infusion of ampicillin. The most commonly used antibiotic in neonates is ampicillin. And just a rapid infusion of ampicillin can displace the bilirubin from albumin. So remember that concept, because later on we'll talk about it, what is the relevance of the bilirubin being dislocated from albumin. Next slide, please. Now, once bilirubin arrives in the liver, it undergoes conjugation. And this is a process where 1 molecule of bilirubin get connected with 2 molecules of UDP glucuronate. And the molecule that is formed is called as a bilirubin diglucuronide. So far, heme broken down into biliverdin release the bilirubin molecule, bilirubin molecule hop on albumin, arrives at the liver, and undergoes conjugation. Okay, next slide, please. Vikram, next slide, please.
It is stuck, and let me share it again.
Okay. आज technical difficulties का दिन है. Yeah, so the phenobarbital, I want to talk about it because a lot of pediatricians, and actually in old days when I was in Pakistan, I also used sometimes phenobarbital, which is what it does is that it increases the concentration of a protein called as the Y protein or ligand 10. It helps in the binding of the bilirubin with that cytoplasmic ligand 10. And then it also induced the enzyme UDPGT, or uridine diphosphate glucuronyl transferase. And that enzyme, you have to understand the role of that enzyme before we move on. So once the bilirubin is arrived and undergoes conjugation, the conjugated bilirubin is the one that can be excreted. And it is excreted with the bile in the intestines. Click on one more time. Once it arrives in the intestine, there's an enzyme in the intestine called as the glucuronidase that can convert it back into unconjugated bilirubin, and it can get reabsorbed. So this concept, this concept of unconjugation again in the intestine and reabsorption is very important for you to understand as we move on to the next slide, that how physiological hyperbilirubinemia can become pathological. Next slide, please. So what is the physiological hyperbilirubinemia? The term is, as we talked about it, adults appear jaundice when the bilirubin is greater than 2 milligram per deciliter. But most newborns have bilirubin greater than 2 milligram per deciliter by the end of life. So all infants are jaundice to some degree by the end of life. In a normal term newborn, the highest level can go up to 6 to 8, as high as 12. But in premature infant, the levels can go up to as high as 15. And understanding this concept of these levels is important, because up to 6 to 8 in the first week of life, and even by the end of the first week of life, up to 12 is still considered as a physiological range. So a newborn who is being examined in an office and appears a certain degree of jaundice, it is common, it is physiological, it is not pathological. Next slide, please. So what is the reason for jaundice in newborns? So the most important reason, if you remember the first slide, we talked about that heme molecule is converted into biliverdin, and the biliverdin is converted into bilirubin. And the newborns are usually in the uterus. They are in an environment called as like a sort of a hypoxia environment. So they need increased amount of red blood cells volume, and that's why they have a higher rate. The RBCs of the newborns have a shorter half-life of about 90 days compared to the RBCs of a term newborn, which is a term newborn or an adult is 120 days. There's ineffective erythropoiesis. There's increased turnover of non-hemoglobin heme proteins, but these are not too much contributory to the jaundice in newborn infants. They are very slight fraction of the contribution to the jaundice. And then the increased enterohepatic circulation secondary to the gut motility. Remember the previous slide where I showed you that the liver released the conjugated bilirubin into the intestine, and from there the deconjugation happens again and get reabsorbed. So this is why they have a high level of jaundice. And then there can be defective uptake of ligand molecule, and then decreased UDPGT activity. I cannot always pronounce this enzyme very clearly. So this is why the physiological hyperbilirubinemia happens. Now, the non-physiological hyperbilirubinemia, this is very important. If a baby appears jaundice before 24 hours of life, that is non-physiological. They should not appear terribly jaundice on the day of life 1. The rate of the rise is greater than 0.5 milligram per deciliter per hour. That is also non-physiological. If the infant has some underlying illness, and this concept is very important, that a lot of time we admit infants with sepsis or acidosis, birth asphyxia, and they also have on the side jaundice going on. I mean, we are not paying attention to that because we are focused more on the primary disease like sepsis or asphyxia. And sometimes jaundice is being missed and the level keep rising up and crosses a threshold where it can cause brain damage and kernicterus. And then the non-physiological hyperbilirubinemia is also if a jaundice is persisting more than 8 days in term and more than 14 days in a preterm infant. So this is how we define non-physiological. Now, this is a picture of a maze. The reason I put it on over there, if you're sitting in a clinic and you are coming up with a baby, who appear jaundice, oh my God, there are so many things that you have to think about. It can be blood group incompatibilities. It can be red blood cell wall defect. It can be breast milk jaundice. It can be breastfeeding jaundice. It can be increased enterohepatic circulation. It can be increased extravascular blood. It can be polycythemia. It can be red cell enzyme deficiencies. So these are the certain etiologies of non-physiological hyperbilirubinemia. And to arrive at a correct diagnosis, you need to take a full history. And you guys know that how I am so focused on history and physical exam. So next slide, please, Vikram. So here it is pretty easy in United States that if you want to figure out what is the maternal blood group type, we just go and pick up the maternal chart and look at the blood group type. But if you do not have that luxury in Pakistan, you want to actually try to get the medical record of the mother and figure out what blood type she has. Did she ever had an antibody screen done on her? Did she had any history of previous pregnancies? Because a mom who is O positive or has Rh incompatibilities, the antibody loads get bigger and bigger with each subsequent pregnancies. So even abortions can increase the load of antibodies in the maternal circulation. Once you know the mom's blood type, then you do the infant's blood type and you can do a Coombs test. And this is only for the blood group incompatibilities where you will be looking at this part of the history. Let's talk about the blood group incompatibility. And I'm trying to explain it to you in the how the lab is look at this data when you send it for the Coombs test. So the mother is usually O positive in an ABO incompatibility. Baby is either A positive or B positive, and we are already only talking about the ABO incompatibility right now. So red blood cells are already coated with antibodies, and when you use the reagent, those red blood cells clump together. Vikram, go ahead and click on one more time. And what happens is the reagent that you use is called as the anti-human IgG Coombs reagent. Click one more time. And this is how your red blood cells have antibodies on it. Click one more time. Again, antibodies on the red blood cells. And when you add the reagent, they clump together. And that's how you know that the Coombs is positive. So in an ABO setup, mother has to be O positive, baby is either A positive or B positive. Next slide, please. So we don't deal with Rh incompatibility here in this part of the world because any mom who is Rh negative and has an antibody load, they always get ROGAM. I don't know what is the situation in Pakistan in terms of antenatal care, that how many moms get ROGAM, but in a rural setup or in a non-urban setup, you have to think about as one of the probabilities. And this is different from the ABO incompatibility because in Rh incompatibility, the mother is Rh negative, baby is Rh positive, and the mom, if she did not receive ROGAM, she have antibodies circulating. And those antibodies, when you add the reagent, clump the red blood cells together. And that's why it is called as an indirect Coombs test, because the antibodies are not coated on the red blood cells. Remember, in ABO incompatibility, the red blood cells are already coated with antibodies. In this situation, in Rh incompatibilities, the antibodies are in the circulation. And once they bind with the red blood cells, that's when they cause this Coombs test positive. Next slide, please. So we talked about in the previous two slides about ABO and Rh incompatibilities. Now, the other reason for the red blood cells to be destroyed very early is because if they have some red blood cell wall defect. Hereditary spherocytosis is common in East European population and certain proportion of Asian population. It is very easy to diagnose if a person has some understanding of how the red blood cell morphology is. Usually a red blood cell appears biconsave, but in hereditary spherocytosis, it appears spherical in shape. And then to confirm, you can do something called as osmotic fragility test. I don't think so you have that luxury of doing it in an infant who is having a severe jaundice and you're in a setup where they may not be an osmotic fragility test. But just putting that blood on a slide and looking under the microscope, you can see those spherical red blood cells. And it is because of a defect in the red blood cell wall protein called spectrin and padenine protein 4.1. So keep that in mind as one of your differential diagnoses if there is not ABO incompatibility or RH incompatibility as a reason for your jaundice. Next slide, please. I'm not going to go into the full pathway of glucose 6-phosphate, how does it do, but what it does is that it stabilizes the red blood cell membrane by generating, converting NADPH into NADP. And this enzyme is actually located on the X chromosome. So a female child cannot have G6PD deficiency, remember that. And then in the male population, depending upon what ethnic group, they can have certain degree of G6PD deficiency. To my recall, there are 70 different variants. The most commonest are G6PD A negative and G6PD B negative. And this A negative and B negative is not the blood group type. This is the enzyme type, the G6PD enzyme type. So I want everybody to be very clear about it. And it is very common in the United States. About 30 to 40,000 babies are born who are African American. They have certain degree of G6PD deficiency. And back when CDC was maintaining the Kernicterus registry, there were 61 infants recorded back in 2005 with Kernicterus, and out of those, 31% had G6PD deficiency. So remember, this is a very important cause of hemolysis. But this hemolysis, I want to remind everyone that Coombs will not be positive. If you do a Coombs test, it will be negative. If you look at the blood group, there will not be any blood group incompatibility. But if an infant appears severely jaundiced, think about this as a possibility if it is a male child, okay? Next slide, please. Next slide.
It is stuck. Just a minute.
Oh, okay, no worries. Yep, perfect. So the other thing, as I said, once you rule out ABO incompatibility, you exclude the probability or possibility of the other ones. Look at the most commonest cause of jaundice, which is extravascular blood. When you will do a detailed history and examination of that infant, there may be a history of vacuum application. When I was in fellowship in early 2000, vacuum was just still a very new thing, but now almost every baby get vacuum application for vaginal delivery. I don't know what is the status in Pakistan, but when you apply that vacuum and you pull the baby, you cause some degree of separation of the blood vessels, and the blood tend to get accumulated in this in the subcutaneous space, and it is called as a cephalhematoma. So examine the baby and see for any cephalhematoma on the skull, because that can be the reason for the jaundice. And then we talked about it, is that if there's increased enterohepatic circulation, it can happen because of the poor intake, infrequent stooling, if an infant has atresia or stenosis, and medical conditions like Hirschsprung meconium ileus or solid blood can also cause increased enterohepatic circulation. So that can also be a risk factor for jaundice if there is increased enterohepatic circulation. Now, the other one that people tend to forget is that the amount of the blood that is available, if it is extra, it is going to get destroyed into biliverdin and then eventually bilirubin. So in polycythemic infant, they tend not to appear terribly jaundiced because the red color of their blood is giving them this ruddy, deep red-purple appearance. And you may miss a clinically significant jaundice in these infants. Remember that if this is a twin and the other twin appears pale, then the recipient twin can have polycythemia. Delayed cord clamping, and people do it different ways. I have had people put the baby below the level of the mom for several minutes. I have seen obstetrician milking the cord. So if you do overzealous delayed cord clamping or all those non-standard way of delayed cord clamping, it can lead to polycythemia. IDM moms, trisomy moms, moms with Graves' disease and hypothyroidism. And remember, in Beckwith-Whiteman syndrome, there can also be polycythemia. Growth retarded infants can be polycythemic because they are chronically hypoxic. And remember that in polycythemia, besides hyperbilirubinemia, these infants are at risk of other complications like seizure because those sluggish red blood cells can get stuck in the cerebral microcirculation and cause microinfarcts. It can lead to respiratory acidosis because red blood cells get stuck into the pulmonary circulation and can lead to pulmonary hypertension and occasionally necrotizing enterocolitis. Now, the next category is the breast milk jaundice. This is probably one of the most commonest jaundice that pediatricians can encounter in their clinic. It is usually late onset. It doesn't happen in the first week of life. Usually start happening in the second to third week of life. Levels can reach up to as high as 20 to 30 milligram per deciliter. And then eventually this bilirubin starts gradually coming down by between 3 to 10 weeks of life. The best way to treat is to discontinue the breastfeeding and substitute with formula for 1 to 2 days, but make sure you communicate to the mom that her milk is not the bad milk and she should not stop breastfeeding. It is just for 1 or 2 days, you stop it and then restart the breastfeeding again. And the possible etiology is glucouronidase, as we've talked about it, that the conjugated bilirubin get reconverted into unconjugated and get reabsorbed. Interestingly, breast milk jaundice, if the level reaches a certain threshold, it can lead to kernicterus. So do not take breast milk jaundice as something very benign. Next slide, please. Now, breastfeeding jaundice is a different one where the hyperbilirubinemia can develop up to like 12 milligram per deciliter. About 13% of the breastfed infants develop some degree of breastfeeding jaundice. Usually onset is first week of life. It is usually because of the decreased milk intake or reduced caloric intake. So those are the two things that can lead to breastfeeding jaundice. And encouraging a frequent breastfeeding. So in breastfeeding jaundice, you want to increase the frequency of breastfeeding. And then I don't know what is the situation in Pakistan, but some mothers try to do glucose water supplementation that can also lead to exaggerated breastfeeding jaundice. Next slide, please. Next slide. Previous one, sorry. Vikram, previous one. Yeah, so transcutaneous bilirubin, that question was asked a couple of days ago on the forum that can people use transcutaneous bilirubin meter for figuring out how the degree of jaundice. Yes, we use it in our newborn nursery, but we don't use it in our NICU and in our preemies. There was an old study published in 2004. They looked at about more than 800 newborns, all were greater than 35 weeks of gestation. And this was a pretty mixed population of whites, about 60%, about like 30% blacks, East Asian, and there were about like 2% Indian and Pakistanis. And what they found is that it is pretty decent way of measuring the bilirubin because it correlates very clearly with the serum bilirubin, except in the Black infants, where the values are usually always higher when they are compared with the serum bilirubin levels. So that is actually a good thing, that when you have an infant who appears jaundice and you put the bilirubin meter and transcutaneous bilirubin meter and the level is higher, especially in a dark skinned person, you may be over exaggerating the jaundice and the serum bilirubin level may be a little bit less. But again, besides transcutaneous bilirubin, I think a good visual examination is also very important. And they measured it in different ranges. They said as long as the level is 15 up to 15, they can measure it pretty effectively. Next slide, please. Now, some people use this thing called as end-tidal carbon monoxide. I do not use it. It is available in the blood sample and the arterial blood sample. and it will give you the CO carboxyhemoglobin level. Honestly, I do not know how to interpret this data. Anybody in the audience who knows it, they can look into it. But I do not use end-tidal carbon monoxide side by side with my bilirubin measurement to ascertain how I want to treat it. I just check the serum bilirubin level and then make my decision about managing that baby based on that serum bilirubin level rather than any other values. Next slide, please. So once you have an infant who is available to you, and you're now thinking of doing clinical tests to figure out that do you want to treat it or not, you do total serum bilirubin. You check for blood type, both Rh and ABO. You look at the peripheral sphere for the morphology and the retic count. And the retic count is very important. Not many people know if retic count is high and your serial hemoglobin or hematocrit is falling and your bilirubin is rising, that means there's an hemolysis going on. And if you have a Coombs positive, that means it's an immune-mediated red blood cell destruction. And if the Coombs is negative, that means it is some kind of a structural defect like G6PD deficiency, spherocytosis. I did not touch base on pyruvate kinase deficiency. It's very uncommon, even in Pakistan. So if you have exhausted everything and you want to test for pyruvate kinase, the sending out that sample is very, very time consuming. And I think very few places run that test. And then obviously always check for the direct bilirubin. So when you're taking care of an infant who appears jaundice, besides measuring the total serum bilirubin level, also measure the direct bilirubin level, because you may be sitting on a baby with conjugated hyperbilirubinemia, and that is a completely separate category. And then also do a G6PD screen. Next slide, we already did that. So I'm still going to talk about the old nomogram. Interesting thing, this happens that when the AP guidelines came out, a lot of folks are still uncomfortably in adapting it. We have these guidelines for almost 4 months. We are still trying to digest that information. We are still trying to change our protocol, both in the newborn nursery and in the NICU. But we are still following the older guidelines and slowly and gradually transitioning into the newer guidelines. So as of now, we are still using the nomogram that was published in 2005, and it has 3 risk zone: low intermediate, high risk, and high risk zone. And you put the baby based on the serum bilirubin level and age in hours. And that is very important. You have to know exactly when the baby was born and when the bilirubin is drawn. And when you put it on the graph, it will give you where the bilirubin fall on this nomogram. Next slide, please. And then you can actually predict the rate of rise. The typical physiological rate of rise is 0.2 milligram per deciliter per hour. That is something that if it is exaggerated, you can anticipate that the baby will develop severe jaundice. But to ascertain how the rate of rise is, you have to have at least 2 serum bilirubin values. Usually people take 4 hours apart to establish a trend and then plot it on this graph. And then they can say that if they do not start the phototherapy, where the bilirubin can appear. Now, next slide, please. Now, this is very important. And I put that this is an infant who is only 17-hour-old and appears jaundice. Nothing biggie, like infants appear jaundice. But in 17-hour-old infant, if the bilirubin is 9.2, that is in the high risk zone. Same amount of bilirubin in a 3-day-old infant is physiological, but in an infant who is under 24 hours old, this amount of bilirubin is non-physiological. Next slide, please. So in this infant, if you do the first bilirubin at 17 hours and it is 9.2, and then you do plot a graph, you can anticipate, next slide, please, where it may go by the 66 hours of life if you do not restart the phototherapy. So the point I'm trying to make is that there can be different ways of looking at it, and it can reach up to the threshold of 25 milligram per deciliter, which is the number that we usually get very scared about and start preparing for the exchange by 66 hours of life. Next slide, please. So general principles of management. Once you get an infant with severe hyperbilirubinemia, you took the history, you established the diagnosis, or you're still trying to establish the diagnosis, you start managing that infant, because you do not want to be waiting for the test results to come back to start phototherapy. And at the same time, you also have other factors that you have to take into account. Avoid medication. Remember the slide I showed you that bilirubin is transported in the blood bound to albumin. So do not give any medication that is albumin bound. And if you're planning to give ampicillin, do not infuse it rapidly. Avoid medical conditions like hypothermia and acidosis. And again, remember I said bilirubin can be the manifestation of another ongoing process. The kid can be septic and can also have severe hyperbilirubinemia. The kid may be a slightly birth asphyxia with acidosis and can have hyperbilirubinemia. The kid may be becoming hypothermic and can also have hyperbilirubinemia. So address those issues also, but at the same time, keep paying attention to the bilirubin level. And obviously, if the infant can be fed, like if the kid is not septic or not asphyxiated, and you want to go ahead and continue with feedings, continue with the feedings, because you'd want to decrease the enterohepatic circulation and you want to improve the urinary output. Next slide, please. So the guidelines for phototherapy, and we are still talking about the old guidelines. We haven't touched base on the newer ones. If you're suspecting RH incompatibility, start the phototherapy right away. Don't even bother checking. Like as you're waiting for the serum bilirubin result to come back, start the phototherapy if it is RH incompatibility and the infant is born in your newborn intensive care unit. And in the ABO, they have different levels. At 12 hours, the level is if the level is greater than 10. At 18 hours, if it is greater than 12, and at 24 hours, if it is greater than 14. Interestingly, these are the guidelines, but sometimes hospitals in the United States make their own policies to avoid the risk of litigation. So in our unit, actually, we do not follow this guideline. We actually, any baby who is ABO incompatible and that get a cord serum bilirubin, that cord serum bilirubin is being plotted on the graph. And if it is in the high risk zone, that baby comes to the NICU for intensive phototherapy and further management. Remember, the level for exchange transfusion is 20 milligram per deciliter if it happens in the first 24 hours of life, and if it is greater than 25 at 48 hours of life. Next slide, please. Now, let's touch base a little bit about the phototherapy. We have here special blue lamps. I know Yasser shared his NICU clinical picture where he had those blue lights, and they have their peak output at 425 to 475 nanometer. The white lamps that are commonly available in most of the newborn intensive care units in Pakistan have a range of 380 to 700. So it's a wider range. It's not a narrow range. But in phototherapy, you need a narrow range of 425 to 475. And what it does, it converts this bilirubin from a 4Z15Z chemical isomer to 4Z15E. But if it is not excreted in the urine, so that's why the urine output is very important, because it is water soluble and it has to be excreted in the urine, because if it doesn't get excreted, it can get converted back to 4Z15Z again. So you start the phototherapy, and at the same time you address the hydration and urine output. It also converts phototherapy also converts the bilirubin into lumirubin, and then it also converts it into smaller polar products that can be water soluble. Next slide, please. Now, the side effects of phototherapy are uncommon, but they are real side effects. So remember, increased water loss, and that's why the baby should be very well hydrated. And sometimes some places start IV hydration also, besides continuing with the feeding under the light. It can cause watery diarrhea, increase fecal weight water loss. Lower calcium can cause retinal damage. So we do put on goggles, like cloth goggles on the infant, or some kind of special covering on the eye to keep the eyes being exposed to the phototherapy. It can cause tanning, especially if this is conjugated hyperbilirubinemia. And remember, I told you that when you're checking the bilirubin, make sure you look at the conjugated bilirubin level. The babies can develop Brown's baby syndrome. And I don't know how many of you may have seen. I have seen at least one or two where in a smaller nursery, the pediatrician started the phototherapy, never checked the conjugated bilirubin, and the baby actually had conjugated hyperbilirubinemia, and the color of the skin was literally bronze in color. It was very, very noticeable. The other side effect of phototherapy, that's where we as pediatrician try to weigh the risk and benefit, is that you take the baby away from the mother. So disrupted maternal child interaction, not fetal. Baby is already born. Sorry about that. And then the phototherapy can change the DNA strands break. It can cause mutations. And that's why there is a side effect that in longer run, babies who are being exposed to phototherapy may develop some kind of cancer. I think Naveed shared a meta-analysis about that a couple of days ago, if I remember correctly. And then if the infant is on TPN, the amino acid tryptophan can be reduced in that TPN. Okay, next slide, please. So the indications for exchange transfusion, and the indications are very, very important. And I'm going to start from the bottom. I wrote it in bold: do not hold phototherapy. So as you are making arrangement for an exchange transfusion, you are not supposed to stop the phototherapy. Continue with all the things that we talked about: hydration, phototherapy, and while you're making arrangements for your exchange transfusion. And the purpose of the exchange transfusion is to remove the antibodies and the already sensitized red blood cells. These infants go through severe hemolysis and they can develop anemia. So sort of an exchange transfusion is also a way to replenish those destroyed red blood cells. And if you start making arrangement for exchange transfusion, if the cord bilirubin level is above 4.5 and the hemoglobin is less than 11, especially in an infant in which you already know that mom is Rh incompatible. So ABO incompatibility will cause hemolysis, but not severe. But Rh incompatibility can cause very severe hemolysis. And if the cord bilirubin level is 4.5, which is not that high, but if you're seeing a hemoglobin which is less than 11, that means there's an ongoing hemolysis. And if you will not remove those sensitized red blood cells, the hemolysis will keep going. The kid will become anemic and severely jaundiced to the point that can develop cardiac arrest. If the rate of level of rise is greater than 1 milligram per deciliter, and then if the bilirubin is already at 20, you start making arrangement or expected to reach 20. And this is the indication for exchange transfusion for an Rh incompatible, because you want to be preemptive in Rh incompatibility. I haven't done any exchange transfusion since 2005 because here we give Rogan. And the only exchange I did was a G6PD deficient infant. I don't know the Rh incompatibility data and prevalence in Pakistan. So be mindful about that in the setup in Pakistan. Next slide, please. So the blood that is needed for exchange transfusion, it has to be a fresh blood, should not be less than 7 days old. It should be preserved in CTD. In Rh hemolytic disease, it should be cross-matched against the mother. I have never done exchange transfusion in ABO incompatible, but if you're dealing with a severe ABO incompatibility, the blood type should be Rh negative or Rh compatible with the mother, and there should be the red blood cells should be suspended in the AB plasma with no antibodies. And the volume for the exchange transfusion is 80 ml per kg, and that is called as a double volume exchange transfusion. Next slide, please. What are the complications of exchange transfusion? It's a very, very invasive procedure. I always tell people, take it with a grain. Don't take the exchange as a simple procedure. It's a complicated procedure, and it can cause severe side effects. So hypocalcemia and hypomagnesemia, those are not that severe. You can correct that. Hypoglycemia, acid-base balance. But the things that can happen is bleeding. It can lead to infection. And in the longer run, if you do more than one exchange, those infants are at risk of developing graft versus host disease in the future if they ever develop any kind of malignancy or immunodeficiency, and they can never be a candidate for bone marrow transplant. So don't let the hemoglobin bilirubin go to the level that you have to do the exchange transfusion. Try to be proactive and manage it without doing the exchange transfusion, and use it only as a last resort therapy. Next slide, please. What are the other treatment modalities for jaundice? Again, as I said, some people use phenobarbital. It's reserved only in the United States setup. It is only reserved for infants who are diagnosed with Gilbert syndrome or Crigler-Najjar syndrome type 2. Otherwise, for other non-physiological hyperbilirubinemia, we do not get phenobarbital. There were some places that they were using oral agar to decrease the enterohepatic circulation. I have never used it. In Europe, they use zinc and tin mesoporphyrin because it actually inhibits the heme oxygenase enzyme and stops the destruction of heme into biliverdin and eventually bilirubin. So I've never used it, but I'm sure that it is an option. I don't know whether it is available in Pakistan or not. And then the important that you want to use is IVIG. If it is an ABO or an RH incompatibility, that is very effective because it can prevent the further destruction of those antibody-coated red blood cells. I have used IVIG quite a number of times when I'm seeing that the rate of rise is still significant in an ABO-compatible infant, and there's a decreasing hematocrit and a rising retic count. But again, it is a good therapy that can prevent you from doing an exchange transfusion. Now, next slide, please. And this is my last slide. So how to remember what are the risk factors in neonatal hyperbilirubinemia? And it is very easy. Just remember the word jaundice. So if you see jaundice, go back to the slide. If you see jaundice in the day of life first, that is a risk factor. Remember, that means this baby is going to develop jaundice to the point that you may end up doing either intensive phototherapy or triple phototherapy or an exchange transfusion. So if you are seeing an infant visibly jaundice on day of life 1, that is a severe risk factor. If there's a history of a sibling with neonatal jaundice or anemia, that means that there may be an RH incompatibility or ABO incompatibility. And then unrecognized hemolysis, both ABO and RH, and then Crigler-Najjar and Gilbert. So if you have already excluded ABO and RH and you have ongoing hemolysis with retic count being high and hematocrit dropping, then consider Crigler-Najjar and Gilbert syndrome as a probability. Non-optimal feeding, we talked about it. Deficiency of G6PD, again, depending upon what kind of population you're dealing with in Pakistan. I think, in my opinion, and there was probably one article that I remember, that in the population of in Balochistan, certain segment, they have a higher degree of G6PD deficiency because they share the same lineage as the African American share with the continent of Africa. Obviously, infection can cause non-physiological hyperbilirubinemia, either viral or bacterial. So when you're dealing with sepsis, just be also mindful about jaundice, because as much as you are paying attention to the etiology in hand, you may miss treating the infant with hyperbilirubinemia, and he or she can develop complication of chronic teres. IDM infants, and then immaturity. And then always look for cephalhematoma or bruising and a central hematocrit greater than 65. And then in E stands for East Asian or Native American or Mediterranean population. So that's where I'm going to stop. And I'm waiting for any questions if anybody has. Thank you.
Thank you so much, sir. So we have a few questions from our participants. Okay. So I will start one by one.
Okay.
So first is from so Dr. Saad.
Okay.
Dr. Saad saying G6PD is rare in female gender, but
it's not.
But okay, it can happen in female. He's saying jaundice in G6PD that you see in newborn is due to conjugation issue, not because of hemolysis.
Okay. So what is the question? I'm sorry.
Sir, question is he's saying it is not it's although rare but can occur in the female.
Sorry for
Go ahead.
sorry.
Go ahead.
Sorry.
You go ahead, Vikram. You go
So
ahead.
my question is that why it cannot occur in the female? Why is rare in female?
For me, yeah, because it's an X-linked enzyme, as I said. The G6PD
No, it's not. It's not the X-linked enzyme. It is essential for the hexamonophosphate shunt. It is equally present in the female as well as in the males. Am I right?
Mm-hmm.
Without G6PD, glucose 6-phosphate dehydrogenases, you cannot continue with your hexo. That's why the hemolysis happen. So the question to me for the SAR, glucose 6-phosphate dehydrogenase deficiency. Why the hemolysis have happened? And can you tell, Saad, why the hemolysis happen in G6PD deficiency? Anybody?
Okay. Yeah.
Sorry. Hello.
Yes, your voice is breaking, so
deficiency cause hemolysis. That's my question. Why it happened?
एक्चुअली डॉक्टर साहब कमेंट था कि फीमेल में रेयर होता है
क्यों वो मैं पूछ रहा हूँ क्यों रेयर होता है G6PD डेफिशिएंसी
साथ अभी देखते हैं और उस पर रिस्पांस कर सकते हैं और दूसरी बात
उनसे पूछ लीजिएगा कि बट my thing is that G6PD वालेकुम अस्सलाम
sorry for interruption, Dr. Nice presentation. Sorry, आपने वो comment, your comment was that it can never happen in female. That was I heard. I think I was driving and that's what I heard. So just like we see females with G6PD deficiency. It's rare, but it is there.
So why it is rare? My question is that why is it rare in females?
Why it is rare? Because because mostly it's an X-linked disease. So X-linked, to have an X-linked, you have to have both either like both the genes, like both the alleles should be affected. So that's why it's rare.
Well, come again. I couldn't get you. That so you are saying it is
G6PD is primarily an X-linked recessive disease. So for
no, I'm not talking about X-linked recessive disease. The G6PD is required to maintain.
We are talking about deficiency.
Yeah. So why the deficiency? Why? Because to me it is equally can happen in the females.
The enzyme level is equal, but the deficiency, because the disease is because it's an X-linked recessive disease, so that's why it is rare in female. But the comment of Dr. Nasir was that it's always seen in male. So my comment was just a comment that we see females with G6PD deficiency. Also, it's not very rare now. Like I work in Saudi Arabia, and I have seen many cases of females. So just to comment.
I think it is happening in the female also, and it is required for both male and female to maintain the normal pathway. Okay. Sorry, go ahead.
Okay, so our next question is from Dr. Sitara. She's asking how we do heliotherapy. Is it effective or not?
What therapy?
I don't.
Heliotherapy.
I have no idea what is heliotherapy. Junaid, you have any idea what is heliotherapy?
No, really not. That's why I asked again.
So may I comment? May I comment, sir?
Yeah.
What is heliotherapy?
Yes.
Actually, sir, heliotherapy basically, जहाँ तक मुझे थोड़ा सा इसका है knowledge, कि बेसिकली वो ये है कि वी कन्वर्ट द सनलाइट, वी फिल्टर द सनलाइट, उसको फिल्टर करके जो यूवी रेडिएशंस हैं वो रिमूव करके देन हम जो है वो यूज़ कर सकते हैं फॉर सनलाइट के लिए और फॉर फोटोथेरेपी के लिए ना, एज अ फोटोथेरेपी. तो बेसिकली टर्म इज यूज फॉर कि व्हेन सनलाइट इज फिल्टर्ड and remove the radiations from sunlight, the we use term is heliotherapy. But I don't know how this mechanism is occur or happened. I don't know.
So I don't have no idea about this therapy. I never heard of it.
Okay, sir. So moving to another questions. Again, that's a question from Dr. Sitara. She is saying in hypothyroidism, which jaundice is most common occurs? Either it is conjugated or unconjugated or both.
Both, but conjugated is a higher proportion. Usually with hypothyroidism, it's conjugated hyperbilirubinemia in my experience. But again, Junaid, do you want to add any few points?
No, the answer is the same. Nasir said it very rightly. The higher proportion is conjugated hyperbilirubinemia, and because again, Nasir explained it very nicely that you have to understand the physiology that of unconjugated and conjugated, and thyroid hormone is related with the conjugated. There's a whole lot of physiology we cannot explain right now, but so that's why in hypothyroidism, conjugated bilirubin is more higher than unconjugated.
Right, sir. Thank you, sir. So another question from Dr. Sitara. She's asked why does rebound hyperbilirubinemia occur? Any reason?
So rebound hyperbilirubinemia, if it is happening, that means you have to be very sure that what are the risks, what is the original etiology. If this is an ABO incompatibility, that means your ongoing hemolysis is going on. If it is RH, obviously, until and unless you address that issue, the bilirubin keeps coming back. Whether it's RH or ABO incompatibility. If it is G6PD deficiency, until and unless all those deficient cells are destroyed, the hyperbilirubinemia can be recurring. But depending upon what the etiology is, you can have rebound hyperbilirubinemia in any baby. Junaid may want to add any other point if he wants to.
No, that's fine. That's fine, Nasir.
Yep.
Okay. So moving for next question from Dr. Jawad. He's asking, baby's jaundice may vary at different part of the body. So where to apply transcutaneous bilirubinemeter to check for bilirubin level?
Honestly, I don't know. I do not use transcutaneous meter. Our nurses use it. I have never used it myself, so I apologize. I don't know the answer. Junaid, you may want to add to that.
Sure. The thing is that I think, I don't know in Nasir practice it is common or not, but we are doing the universal bilirubin screening, and this is to check the bilirubin by the transcutaneous method at 24 hours age before discharge. And there are two places we are putting: on the chest, in the sternum, and at the forehead. And then we calculate. We always, calibrate our machines, our instrument with the our lab results. So it is not more than 2 to 3 milligram per deciliter or 1 to 2 milligram per deciliter difference between the two. So it is a quite handy to do this thing and avoid rather than very high bilirubin readmissions.
Okay.
Right.
Can I add just one more point on? I want to just add one more point. So in the setup where we are in the NICU, we don't take care of the newborns. So obviously, we don't do the transcutaneous bilirubin as Junaid is explaining very well, that putting it on the chest or the forehead. But the most important observation, ये मैं आप लोगों को एक तजर्बा बता रहा हूँ, by doing neonatology for a long time. आप अपनी जो thumb होता है ना, उसको पटेला जो होते हैं ना, जो anterior bone होती है on the kneecap, अगर उस पे आप press hard करें and you let it go and you see the yellow color over there, that is a very good correlation of a bilirubin which is going to be high. मैंने मतलब मेरे पास जितने भी बच्चे आते हैं सबसे पहले I check the bilirubin, the yellow color on the patella bone, and when the infants go home, जो हमारी discharge teaching है for the parents when they need to come back or seek help again, is to check for yellow color on the patella bone, that they hold the leg of the baby with their fingers and then press hard on the patella bone with the thumb for 1 to 3 seconds and then let it go. And when they let it go, the color on the patella bone gives them an idea if it is getting darker shade of yellow, and if it is progressively getting darker and darker, that means the baby has to be seen by a pediatrician. जो आंख में देखने वाला जॉन्डिस है ना, वो बच्चों पे लागू इसलिए नहीं होता कि bilirubin level is always high in babies. So if you look at in the sclera, they always appear jaundice. Okay.
So another question is from Dr. Jawad. He's saying, asking a question. I have received a 9 days old baby today who's deeply jaundiced. He may need exchange, but his cord has fallen and it's completely dry. If needed, how can I do exchange?
So we get a lot of babies from outside, about 20 to 30 babies a day, a year, 2 admissions, 1 to 2 admissions a year, that they are usually more than a week old. The cord has fallen off. But if the stump is already there and you wrap it with a wet gauze and let it sit there for 30 to 45 minutes, it soften up, and then when you cut it, you can see the umbilical vein. I have put umbilical lines in babies as far out as 11th or 12th day. Obviously, you have to do it in a very under aseptic condition because that cord has been dry and colonized. So you have to make sure that after you have dried, you wet the cord, let it soften. When you are about to explore, you clean it many times. The typical cleaning time is like 3 times with betadine. I usually do 4 to 5 times. And when I cut the cord, I clean it again a couple of times, and then with the alcohol and the whole area around the abdomen before putting a line in. And the other option is to put an art line, either on an umbilical artery, not the umbilical, I'm sorry, the radial artery, and putting a large bore catheter in the brachiocephalic vein. But that is a bit tricky in a rural setup. I don't know how many people can do that. It's a tricky procedure. Junaid or Naveed may want to add if they have done that differently.
Oh, the simple, you told that even in the 7-9 days, if you cut the cord and, put them on normal line, you can still have the UVC. If not, then simply put the arterial line. Okay. So with the radial artery, you can easily do it.
Yes, sir. Even though, sir, I have remember one patient. During the on-call day, एक बच्चा था, newborn था, वो भी around 10 days old था. So umbilical cord was not present. So fortunately, radial arterial line was picked, and we did exchange in that baby. So we can go for it easily.
Exactly.
So moving for next question. Question is from Dr. Sajid. He's asking, eosine melamide EMA binding test is a flow cytometric test and is increasingly used to detect hereditary spherocytosis. Are you doing it in USA?
Yeah, the prevalence of hereditary spherocytosis in US is very low. I have never seen a patient of hereditary spherocytosis. There was only one infant that we were suspecting, and I think we did this test, this test EMA. And we are sort of spoiled here because what happens is that if we want to get anything done, we just call the lab and say, figure it out. We are going to send the blood sample, and they figure it out. So I'm sure this was the same test. If I recall, I did it. But Junaid or Naveed may have seen more cases of hereditary spherocytosis and may have used this as a modality to diagnose. What is your experience?
No, I don't have the experience about that, because in USA where I was and where I am now and here in UAE, we didn't see the hereditary spherocytosis that much.
Yeah.
Okay. Oh, and so another question is from Dr. Hanifullah. He's asking, is there any effect of sunlight on jaundice? As we advise to our patient after discharge के बच्चे को धूप में रखें, अगर फायदा हो तो कितने टाइम तक सनलाइट के लिए एक्सपोज करना चाहिए?
जी नासिर साहब फरमाइए।
मैं अच्छा पहले तो मैं इसको कहता कि ये बिल्कुल ही फजूल, मतलब दिस इज अ फजूल recommendation, लेकिन I did the research on this topic. You know how the phototherapy was discovered? There was a nurse in 1800 in England who made the observation that if the babies are jaundiced and you put them on the sunlight, the jaundice start fading, and that's how the research started. So this is not wrong. The problem is that if you do not give the right recommendation to the mom and say ये सिर्फ धूप को में रखना है इस बच्चे को और don't worry about it, तो बच्चा ये होगा कि या तो वो बच्चा जो है डिहाइड्रेटेड हो जाएगा या जो है ना वो अगर उसको कॉन्जुगेटेड हाइपरबिलिरुबिनेमिया होना तो उसको ब्राउन बेबी सिंड्रोम हो जाएगा. So you have to explain everything in detail that why you want to do it. Go ahead.
And I want to add another thing कि ये जो sunlight होती है ना, of course इसका is a very efficacious और उसका बहुत ज्यादा इफेक्ट है, मगर mind it is a ultraviolet rays, ठीक है, तो that's you have to consider. तो जब भी कभी माँ को एडवाइस करें कि डायरेक्ट सनलाइट पे ना हो, किसी के थ्रू हो के कहीं से इनडायरेक्टली सनलाइट पड़ रही हो, ठीक है, तो दैट्स ओके. एंड देन यू कैन नॉट, it is the same like intensive therapy, do not put the baby more than 4 hours in direct sunlight पे, ठीक है, और उसके बाद आप हटा लें और फिर 4 घंटे का जैसे इंटेंसिव फोटोथेरेपी है. मुझे ये नासिर से सवाल पूछना था लेकिन आफ्टर दिस, लेकिन बहरहाल दिस इज द वे इफ यू एडवाइस, बट ट्राई कि भाई उसको बहुत अच्छी तरह माँ को एक्सप्लेन कर दें कि इसके बहुत साइड इफेक्ट्स हो सकते हैं. ये नहीं कि वो डायरेक्ट धूप में जाके रख दे तो इट्स वेरी आई मीन सबसे पहले तो उसको डिहाइड्रेशन हो जाएगी.
तो एक्चुअली हेलियोथेरेपी का जो कांसेप्ट जो था ना वो जो उन्होंने पूछा था बेसिकली वो यही है कि आप वो बेसिकली वो शीट्स के बारे में मैंने कहीं पढ़ा था, आई थिंक अप टू डेट पे कहीं पढ़ा था मैंने कि जो है वो शीट्स जो है विंडो में वो यूज करते हैं, फिर उसके बाद जो रिफ्लेक्शन होके उसके बाद जो है वो दिस इज हाउ वी कैन हेलियोथेरेपी. अनदर क्वेश्चन इज व्हाट इज सिंगल फोटोथेरेपी, डबल फोटोथेरेपी एंड ट्रिपल फोटोथेरेपी?
ये मुझे भी पूछना था नासिर से कि इसका क्या मतलब है.
यार मुझे भी, देखो मैं आपको एक बार बताऊं, हम तो ये टर्म यूज नहीं करते सिंगल, डबल और ट्रिपल. वी यूज द कन्वेंशनल एंड इंटेंसिव फोटोथेरेपी. So conventional phototherapy is just one big lamp, the blue lamp, on one side of the baby. If we put 2 of those lamps together, then we call it intensive phototherapy. और कुछ बच्चों में जब हमें बहुत ज्यादा करनी होती है, एरिया एक्सपोज करना होता है, तो what we do is that we cut the diaper completely just to cover the front part of the body, and then we expose the baby maximally. और कभी कभार मैंने यूज किया, 2-3 दफा यूज किया कि एल्युमिनियम फॉइल जो होती है ना, टिन फॉइल जो होती है जो रैप करते हैं खाने, वो भी मैंने एक्चुअली बिछाई है ताकि टू इंक्रीज द एक्सपोजर ऑफ द बेबी. आई डोंट नो इफ यू एनी वन ऑफ यू हैव यूज्ड दैट.
या आई थिंक द कांसेप्ट इज रॉन्ग कि ये डबल और फोटो, ये है कि आप कितना एरिया एक्सपोज कर रहे हैं. तो सिंगल फोटोथेरेपी इज इक्वल टू एनी फोटोथेरेपी कि अगर उसका एरिया उतना ही है, आप 2 फोटोथेरेपी लगा दें, इधर से रेज आ रही हैं उधर से रेज आ रही हैं, ठीक है ना, मगर एक्सपोज वो सिर्फ सामने का हिस्सा ही कर रहा है. तो द कंसेप्ट इज कि डबल फोटोथेरेपी व्हेन यू पुट द बिली ब्लैंकेट ऑन द बैक and on top of that you are providing, so now you are exposing whole baby. So this is the concept of double phototherapy. There is no such thing called triple phototherapy. After that we use the intensive phototherapy. लेकिन चूंकि we are using the LED lights, so LED lights itself is intensive phototherapy, is we call it cool lights क्योंकि वो गर्म नहीं होती, मैंने शायद अपने last lecture में भी बताया था. तो anyway, so these are the, if you have halogen lights and the baby is not improving, try this billy blanket to cover the back of the baby and on top. So this is called double phototherapy to cover the maximum area. So that's the concept is to, as Nasir is also saying कि जितना आप उसको बच्चे को Yeah.
Ji, can I add a bit of thing into it, Junaid sir? Assalamu alaikum.
जी वालेकुम अस्सलाम।
तलाल है, प्रोफेसर तलाल बोल रहा हूँ जी।
हाँ जी,
इसी
तलाल,
में
तलाल।
आपकी फोटोथेरेपी वाली 2-3
जी,
चीज
जी।
आपने मुझे कहा है अनम्यूट कर दो, तो इफ यू गिव मी परमिशन। आपकी चीज इंटेंसिव फोटोथेरेपी बेसिकली यू नीड टू नो द स्पेक्ट्रल इरेडियंस, एंड स्पेक्ट्रल इरेडियंस जो है वो आपके सरफेस एरिया पे डिपेंड करती है और एक्सपोजर पे डिपेंड करती है और लाइट की इंटेंसिटी पे डिपेंड करती है। और जो डेफिनेशन वो ये कि अगर आपकी 30 माइक्रोवाट्स का कोई वो एक लंबा सा है यूनिट्स है उसके, अगर वो होती है तो दैट इज नोन एज इंटेंसिव फोटोथेरेपी। एक चीज
जी,
अच्छा,
बिल्कुल।
दूसरी चीज फोटोथेरेपी जब आप देंगे तो डिस्टेंस वाइज भी आपको हाँ, लोगों ने बात की है सनलाइट की। द इशू विद सनलाइट इज दैट यू एक्चुअली नीड अ वेरी वेरी नैरो रेंज फॉर फोटोथेरेपी टू बी इफेक्टिव। दैट इज समथिंग बिटवीन 465 to 475। अब सनलाइट में बहुत सारी वाइड रेंज है, एंड दैट वाइड रेंज अकॉर्डिंग टू भूटानी साहब जो कि इस पे अथॉरिटी है, ही केम टू पाकिस्तान एंड वी हैड अ लॉट ऑफ डिस्कशन उसके साथ भी इस चीज पे, उसमें बहुत ज्यादा रेंज है। और आपकी बात बिल्कुल ठीक है जुनैद साहब कि उसमें अल्ट्रावायलेट का भी एस्पेक्ट है और कुछ कार्सिनोजेनिक और स्किन कैंसर और इस तरह की चीजें
ऑफ कोर्स
का रिस्क हो सकता है। नॉट सेइंग कि वो प्रूवन है, बट दैट इज, सो यू नीड एक्चुअली अ वेरी नैरो रेंज, और वो नैरो रेंज तो आपको नहीं मिलेगी, आपको ब्रॉड रेंज सारी सनलाइट पे देनी पड़ेगी। बट यस, जहाँ हालात ऐसे है तो वो आप दे सकते हैं। अगली चीज जो आपने शुरू में बात की थी, एक क्वेश्चन है मेरा, वो मैं बाद में, हाँ, G6PD की जो जीन होती है, इट शेयर्स द सेम जीन विद रेगुलर नेचर, और उसमें भी रिलेटिव डेफिशिएंसी होती है जो कि आपकी ग्लूकोलाइड ट्रांसफरेज की होती है। सो मोस्ट ऑफ द G6PD आर नॉट डेफिशिएंट सेकेंडरी टू a huge hemolysis. It can take place, no doubt, but there is a fair element of deficiency, a relative deficiency of regular Najar also. But I mean, uridinotransferase का element होता है उसमें. So that is the reason कि G6PD वाले काफी जॉन्डिस, जो शुरू में जॉन्डिस होता है, बाद में अगर उनको हेमोलिसिस हो तो दैट कैन बी सेकेंडरी टू पे दिस थिंग G6PD। अच्छा, गाइडलाइंस की हम बात करना चाहेंगे नासिर साहब। What's your thought on this thing? जो American based guidelines है, are they practical in Pakistan or not? I want to know this view of a couple of people, because there are two schools of the two basic thoughts जो है वो है, एक nice guidelines हैं जो British guidelines हैं, और दूसरी जो गाइडलाइंस है वो AP की गाइडलाइंस है जो भूटानी ने बनाई। अब वो रिस्क बेस्ड है। इन आवर सेटअप वेयर वी आर डीलिंग विद फार फ्लंग एरिया, हिस्ट्री, आप डेफिनेटली, कोई शक ही नहीं है कि हिस्ट्री की एक अहमियत है, लेकिन क्या वो हिस्ट्री हर वक्त हमारे जूनियर डॉक्टर्स को अवेलेबल होती है कि नहीं होती? एट टाइम्स नहीं भी होती। सो उस रिस्क बेस्ड असेसमेंट में जिधर हमने बार बार करना है और रिस्क करके और इंटरमीडिएट रिस्क से हाई रिस्क में जाना है, और वो क्या ये पाकिस्तान में पॉसिबिलिटी है? आई वांट टू नो पीपल्स व्यू ऑन दिस, and then I'll give you my thought on this thing. Nice guidelines make
I think for Pakistan, nice guidelines are better because
that's what I wanted you to say. Thank you very much. That's true.
Because one reason you already give. The second reason, with the risk, also with the high risk, intermediate risk, low risk, okay, it is not that easy to understand. And then after certain days, if you and that after certain days, अगर आप ये देखें कि नाइस गाइडलाइन में वो इट बिकम स्ट्रेट, ओके। अच्छा, दूसरा प्रॉब्लम ये है कि 144 आवर्स के बाद भूटानी का ग्राफ ठुस हो जाता है, ठीक है। हमारे तो 6 दिन में 5 दिन में आ रहा है बच्चा, तो that's thing that के नाइस गाइडलाइन
और हमें उसमें बिल्कुल absolutely I only endorse this point. हमारे लिए I've been using nice guidelines for God's ages, अब काफी 10 साल से we've been using it. अल्हम्दुलिल्लाह, not a problem. हमारे यहाँ हमें तो ब्लड ग्रुप नहीं पता था माँ से, सीधी बात है। ठीक है, फिर हमें कैसे पता लगेगा कि ये 6 घंटे पहले क्या था और 6 घंटे बाद क्या होगा? हम तो दिन में प्रॉब्ली एक सेटअप में एक दफा करा सकते हैं बिलीरुबिन, वो भी 6 घंटे के बाद रिपोर्ट आएगी, ठीक है। वी डोंट हैव स्पिन, वो कैपिलरी स्पिन, वो क्या सेंट्रीफ्यूज हमारे तो नहीं है एमआईसीयू।
अच्छा।
सो आई थिंक कि जो नाइस गाइडलाइंस है, दे आर फार इजियर, though there is school of who says they're not as evidence based as Americans are. Americans की भी issue है, but वो probably ज़्यादा आसान है पाकिस्तानी setups में, and they're easier to understand and more
बिल्कुल, that's why I'm
easy for
saying.
us.
हाँ, that's why I'm saying.
बिल्कुल,
the
हाँ जी,
दूसरी ये कि है ना, the Bhutani guidelines or AP guidelines is not for premature babies. It's a 35 weeks and above. Okay, 36 weeks.
exactly.
So if you have a
जी,
34, 32, 31, you have to go through
बिल्कुल,
towards nice guidelines. You got my point?
बिल्कुल,
जी.
बिल्कुल, exactly.
Can I
And
just
one fine for आखिरी चीज एक जी, sure. जी,
No,
मैं
no,
एक आखिरी
Dr.
चीज
Talal,
just for
finish
our
up.
junior
आप finish
जी,
up कर रहे हैं,
just
फिर
last thing
मुझे एक point add करना है.
it's very important to note कीजिए, जो आपने एक चीज हमारे यहाँ बहुत देखी गई है, breast feeding jaundice, which is basically inadequacy of breast milk. उसमें ये बहुत जरूरी है कि we must ascertain कि weight loss जो है, बड़ी छोटी सी point है, लेकिन unfortunately हमारे यहाँ बड़ा मुश्किल है कि जी weight loss जो है वो कितना हुआ है. Is it more than 15 to 20%? If it's more than 15 to 20%, your baby is jaundice, that means your baby is massively dehydrated. So you need to act upon it quickly, and this is most likely inadequacy of breast milk, which is called breastfeeding jaundice, which is a misnomer basically. So these were just a few points. Thank you very much. Pleasure.
चल,
तो दो पॉइंट से मुझे दो पॉइंट ऐड
जी.
करने हैं. एपी की गाइडलाइन जब 2004 में आई थी तो उसकी वजह ये थी कि रिस्क the incidence of connectaris was gradually rising in late 90s and early 2000s. तो उसमें ये they are very strict guidelines that should not be applicable to a country like Pakistan, because obviously the guidelines were developed primarily for the reason of like risk management, lawsuits and all that purposes. That's the one point. The other point is that आप अगर अभी जो नई guidelines देखें तो they are actually more practical for Pakistan, because उसमें जो threshold for starting phototherapy they have changed, and actually they can let the level go up as high as like 22 in a term infant before doing anything, like let alone doing an exchange or anything. तो ये है कि
आपकी बात
मतलब
बिल्कुल जायज है उसमें, लेकिन अनफॉर्चुनेटली जी हमारे सेटअप में जो प्रॉब्लम इज दिस कि हम वो एग्जैक्ट उसमें हिस्ट्री के ढेर सारे पॉइंट्स हैं, वो सारे बहुत सारी चीजें अनफॉर्चुनेटली सिस्टम सपोर्टिव नहीं है उसमें. जुनैद साहब would bear me out कि वो सिस्टम सपोर्टिव नहीं है. मेरा नहीं ख्याल कि हम उसको इस लेटर एंड स्पिरिट में इस्तेमाल कर सकते हैं कि वो हम उसको पहले इंटरमीडिएट में रखें और फिर हाई में जाएं और वो करें. That's obviously you can beg to differ, और अल्हम्दुलिल्लाह किसी का डिफरेंट व्यू डेफिनेटली हो सकता है, एक्सपीरियंस डिफरेंट हो, लेकिन इन आवर एक्सपीरियंस बड़ा मुश्किल है अमेरिकन गाइडलाइन फॉलो करना. दैट्स ऑल.
Right, sir.
Okay.
Sir, Dr. Faisal is raised the hand, and I think want to ask the question. Dr. Faisal.
Assalamualaikum, everybody.
Welcome.
Dr. Nasir, thank you so much for an excellent presentation, as usual. I have few comments and then one question for the juniors and one question for the seniors as well. So my comment, like I would like.
Before you go, please explain who is junior and who is senior. I consider myself both junior. So what is the question for the juniors?
That's so kind of you then. So the comment is, I'd like to second Dr. Saad that we have seen even female babies having G6PD. And the second thing is a question from my side is that we have talked about that if mother is O and the baby is A, then we have ABO incompatibility. Now the question is, if the mother is A and the baby is B, is there any incompatibility?
So this question is from senior or junior, sir?
It's for Nasir.
Ji, sir?
It's for Nasir.
No, there's no. I do not know of that. If the setup you describe, Faisal, I do not think that there's any blood group incompatibility.
What I know, because in case the mother is A, then the mother is having antibodies against B. So theoretically, yes, there is incompatibility, but the antibodies, the size is bigger, so that it doesn't cross the placenta. That's why the jaundice, the risk of the jaundice is not there. So usually when the mother is O and she's having antibodies against A and B. These antibodies are smaller, which cross and cause jaundice or hemolysis in the baby.
Okay.
Good. Yes, sir. Because
Yeah.
of size is almost in case of the mother is O, the size is almost 7S. However, in case of the if mother is A or B, the size is almost 17 of antibodies. So yes, sir, agreed. You're right. Okay. Group should be usually O because of small size, it can easily can cross the placenta.
Exactly. All right. So the next question is, like, we have seen many babies here in Middle East. We see some, a lot of RH problem. So not all RH, even if there is incompatibility, some of the babies, even if they have, we have read this in books that RH incompatibility as compared to ABO is more severe. But some babies, even though if they have incompatibility, they might not need phototherapy or the intervention. This is the comment. Now, the question in regards to RH disease is that if, a baby required, mother is RH ISO, and the baby needed intrauterine transfusion, many times we see that these babies, when they're born, they can even have direct hyperbilirubinemia. So my question to the seniors is, like, will you consider RH ISO immunization? A baby required like 4 or 5 intratransfusions. So will you consider phototherapy as contraindicated in this baby who has direct hyperbilirubinemia?
Right.
So, Faisal, आपका question जो मुझे समझ आया वो ये कि a baby who we knew that RH incompatibility got in utero transfusion several times and then at birth has conjugated hyperbilirubinemia, and should we do a phototherapy on that infant? Is that what your question is?
Exactly.
यार मेरा अपना तो मुझे this is what I know, but then Dr. Huff is also raising his hand. He can also cite comment, and Junaid can also. I don't think so. We should be doing the phototherapy just for conjugated hyperbilirubinemia. If it is severe hyperbilirubinemia, remember the reason for doing the exchange transfusion is the total serum bilirubin. Then you don't worry about the conjugated or unconjugated. But when it comes to phototherapy, I think anything greater than 2, you are going to increase the risk of exposure of the baby and cause Bronze baby syndrome. That is my opinion. But again, Dr. Huff and Jeanette can comment.
May I add few words, sir, if you allow?
Sure.
So actually, the question of sir is very much important. I have read just today from I think new recent guideline. In these cases, especially agar ke hyperbilirubinemia direct component, if it is more than 50% of overall total, then the phototherapy light is contraindicated. Agar ke wo less than 50% hai, so we can use phototherapy in that case, but with cautionly, as we all know, it may cause the Bronze baby syndrome. So it is a overall percentage of the value, if I'm not wrong, because I have just read from the today, I think recent guideline.
Can we take the comment of Dr. Huff?
Assalamualaikum. I think thank you, Dr. Nasir, for your presentation. 2 questions and 1 comment is about this conjugated hyperbilirubinemia. I would, as you do, I would not use phototherapy for conjugated hyperbilirubinemia. It depends on the proportion, of course, but from the scenario which was presented, that the baby has had intrauterine transfusions and then at birth has got conjugated hyperbilirubinemia, I would not use phototherapy. But my question to Dr. Nasir is that the new American Academy of Pediatric guidelines, they have made 25 recommendations, of which 48% are based on opinion, which is the lowest form of evidence. How valid is that? How valid is that guideline?
So, Dr. Halko, that is the dilemma that we are also facing, because when we read the paper first time, obviously anything coming from A, B, we have to read it as if it is a policy statement. But the same argument that you have raised is the same argument is being raised within the pediatrician community here where I'm practicing, and among the group of neonatologists that we are part of, is that how we can apply these guidelines where most of the data is, most of the recommendations are opinions rather than based on scientific evidence. So this is something, a debate that ongoing. हमने तो adopt नहीं किए हैं guidelines. जो नई guidelines हैं वो अभी तक हमने adopt नहीं करी हैं. We're still digesting and going through it, and we don't know whether we'll adapt it completely. We'll probably come up with something of an older and some of a newer version according to the situation of our setup. But that's the problem.
Precisely. I think that's where I think Junaid and Talal's point comes into play, that nice guidelines are much better for Pakistan, at least.
Yes, yes, definitely.
Any comment from Dr. Sajid? Dr. Sajid, are you hear me?
Hello, yes. Nasir, can you hear me?
Yes.
Hello?
Yes, sir, we can
Actually,
hear you.
I have sent the question, but that was missed. That's just for clarification. So, if there is a baby with a conjugated hyperbilirubinemia, and the total bilirubin is very high, and the unconjugated is very sky high, although its a conjugated fraction is high, and we have classified it as a conjugated hyperbilirubinemia. So, considering a very high total and very high unconjugated, so would you recommend phototherapy in that or not? This is a question which was partially discussed before as well.
Can I answer this question, please, if you allow?
Yes, please.
Well, actually, we had, I think, 2 or 3 babies, and we got into this dilemma that these babies who had intrauterine transfusion, and then we started the phototherapy, and we found out the babies have direct hyperbilirubinemia. So we tried to search the literature and found that in these special cases, it specifically mentioned to go with the total bilirubin. I mean, do not consider the direct hyperbilirubinemia. And also because saving the brain is much more important than considering the bronze baby syndrome, which could be reversible.